I'm Terrie Perry, a transfusion practitioner at Milton Keynes University Hospital, and I'm on the line with Caroline Lowe, who apologises that her camera isn't working. So patient sampling errors. I just want to make it clear before we start that in this presentation, we're talking about all sampling errors, not just wrong blood in tube. So we are talking about labelling errors, mismatches between forms and samples. So where perhaps the sample and form don't match, or where the sample and form may even have different information on. But we will, of course, talk a little bit about wrong blood in tubes, WBITs as we call them in the trade, there is research that shows that mislabeled samples are actually more likely to be wrong blood in tubes. So what is a wrong blood in tube? And here we have the definition of it. So blood's taken from the wrong patient, but it's labelled with the intended patient's details, or it's taken from the correct patient, but labelled with somebody else's details. You might personally, personally think that one particular scenario is worse than the other. I do, but they are counted equally, particularly when it comes to reporting to SHOT. These errors are more common than we actually think, because many of us are the same blood group anyway, and so we don't always pick them up. So they're probably very underreported and probably much more common than we think. But for midwives, if this happens and you take a wrong blood in tube, the results can be detrimental for both mum and for baby. What might the consequences be of a sample mix-up like this? So mislabeling errors, wrong blood or wrong blood in tubes, can result in an undetected antibody, perhaps, that's developed in pregnancy. So we could miss hemolytic disease, couldn't we? Because we might have taken blood from the wrong patient and it's gone through as a different patient. We might miss giving somebody anti-D prophylaxis because we group them as Rh negative and they're really Rh positive. We might give them an unnecessary anti-D injection because we think that they're negative, but actually they're positive and we've had the blood from the wrong patient. Remember too that hematology and chemistry, wrong blood in tubes for those can be just as dangerous, because if you get the wrong hemoglobin, you can be transfusing somebody unnecessarily. Wrong chemistry, you get wrong sodium. The potential is terrible to think about. And of course, cord sample mislabeling, which now SHOT has started to be very interested in, can lead to a missed anti-D, because if we mislabel or take, label the cord as and then we find that it's Rh negative, we wouldn't give anti-D. And if it was the wrong cord, the wrong details on the bottle, of course, and maybe the patient, the woman should have had anti-D. So the consequences of wrong blood in tubes and mislabeling can be very serious and affect both mum and baby. You've heard it all before, we know, but wait, because actually we want to look at this problem from a different perspective today.
Okay, so let's start at the beginning and we'll look at this incident. The incident on this slide happened a few years ago, and it was more likely to occur then, as blood bank did not cross-match blood without having the historical group on the lab computer system to confirm that they had the correct patient and the correct patient was bled. If we look at this incident, it was a group and save sample taken on a patient at first presentation at a hospital, and the patient grouped as B negative. The patient had a GI bleed and actually required a transfusion. On that particular day, there was no B neg in stock in the laboratory, so they issued O neg as a suitable alternative, and that patient had 2 units of blood, was successfully treated and discharged a few days later. Unfortunately, the patient turned up 1 month later with another GI bleed, entered the ED department, and a sample was taken. On this occasion, the sample grouped as O positive, so it did not match the group that was historical. The laboratory asked for a repeat sample just to confirm, and yes, indeed, this patient was O positive. So in this case, it was lucky for the patient on the day the blood bank did not have any B negative blood in stock, and they issued the O neg as a substitution, because had that patient had B negative blood that day, they would have received an ABO incompatible transfusion with severe consequences and perhaps even death. So this is way back when we did not have the second samples. Next slide, please, Terrie. The BSH guidance is published in 2012 said that unless secure electronic patient ID systems are in place, a second confirmatory blood sample should be requested for confirmation of the ABO group of a first-time patient prior to transfusion, where this does not impede the delivery of urgent blood components. So in reality, we were talking about a two-sample rule, which we believe should have been called the check the group rule. Next slide, please, Terrie. So was that successful? Well, since the introduction of the group check policy prior to transfusion, many ABO incompatible transfusion incidences have been avoided, but it has also led to an increase in duplicated samples where people are taking two samples just in case. They're not sure why they're taking two samples. But is it a success? Generally, it has been a success, but this incident here will show you that it can have a workaround. In this case, a phlebotomist on a busy pre-Christmas afternoon on a ward was asked by two junior doctors to take a sample on a patient for a group and save as the patient required a transfusion. The patient was in a side room. The phlebotomist was rushing. She was late going for an afternoon pre-Christmas drinks, and she agreed to do it as it was Christmas, basically. She was helping out. So she popped into the side room. She knew about the second sample, two sample rule and actually took two samples. She came out of the room and handed the samples to both doctors. They also knew about the check group second sample rule and labelled the samples independently of each other away from the patient, putting the time of 12:20 on one sample and 12:30 on the other, and signing and dating, confirming that the two samples had been taken independently by two different people at two different times. Blood bank received the samples. They were correctly labelled and processed accordingly, and 2 units of blood requested on the patient. Both samples grouped as A positive. However, the lab did have a historical group on this patient, and it was O positive. So yet again, an incident of where somebody could have had an ABO incompatible transfusion due to sampling error. Next slide, please, Terrie. So does technology prevent these errors? The use of electronic identification systems has been shown to lower the incidence of near misses, such as the wrong blood in tube, but if it's not used correctly or staff are not properly trained, the errors will still occur. The last example I showed you was about workarounds, but we're all familiar with the scanning of the patient's wristband in the notes, or the label in the notes, rather than the wristband on the patient. You need to think about where you prepare your paperwork, and particularly as midwives going out into the community and taking samples. What do you do about blood tests? How do you prepare to label your samples, and what paperwork do you take? Next slide, please, Terrie. So we did look at an incident where there was some IT input, and it just shows that there are still workarounds. In this incident, the correct PID and process was not followed when using IT. In the early hours of the morning, a doctor offered to take a sample for a nurse, and it was samples for full blood count, chemistry, group and save, and a 2-unit cross match. The reason the offer was made was the nurse had tried a couple of times and was unsuccessful. Wanting to help the doctor, the nurse decided to print off some labels for the samples for chemistry and hematology, and some forms, including the group and save request. The doctor was told that the patient was in Bay 2, bed 4. The doctor was unfamiliar with the ward, the lights were down, the patient was sleepy, and we know that there was no PID carried out at the patient's bedside, and the bloods were taken. At the nurse's station, the labels were applied to the full blood count chemistry. The group and save sample was handwritten, as that was a requirement at the trust, using the details from the form that had been produced. and everything was sent to the laboratory. The error was only discovered when the chemistry department phoned to say that the results were erroneous, completely different from what had been given early in the day for that patient. Blood bank were contacted, and they had to take back the 2 units of blood, which they had already cross-matched and was ready for collection for the patient. What had actually happened was that the doctor had bled the patient in Bay 4, bed 2, the wrong patient, who luckily had the same blood group as the patient in Bay 2, bed 4. They were both O-pos. If chemistry had not actually had any samples taken and the results were comparable, we'd never have known about this, and the patient would have had the group of O-neg blood without any issues, unless, of course, that patient had antibodies and we could have been dealing with some hemolytic reaction. Next slide, please, Terrie. These are quotes that we found from some of our incident investigations. When we read them, we see things like the wristband was on the sidebar of the patient's bed. The patient was asleep, the lights were down. The samples were unlabeled. I chased the doctor down the corridor and asked her to return to the ward to label the samples. The shift was not busy, but I was trying to be efficient. Next slide, over to you, Terrie.
So BSH, the British Society for Haematology, do have some guidance about blood sampling, and it's very clear. It says we should have one patient, one competent member of staff, and the sampling performed as one continuous, uninterrupted event. And I'm sure you're thinking, if only that were possible in your busy areas, but that is what the guidance does say. Many of you will know what SHOT is, but for those of you who don't, SHOT is the serious hazards of transfusion. It's the UK's independent, professionally led haemovigilance scheme. And since 1996, they've been collecting and analysing anonymised information on all adverse events and reactions in blood transfusion from all the healthcare organisations in the United Kingdom. And where risks and problems are identified, SHOT produce recommendations to improve patient safety. This is from last year's SHOT report. This year's SHOT report will come out in July this year. But it's the same every year, really, that about 80% of the reports to them each year are errors, and many of them are preventable. And of course, wrong blood in tube comes into that category of an error. And looking at the next slide, this one, you can see the causes of the wrong blood in tube is stated by the reporters. So you can see that there are 2 main causes from the graph. You can see there are 2 main causes of wrong blood in tube errors, and there's 700 errors and nearly 800 errors every year of wrong blood in tube across the UK, which is quite a lot of patients put at risk. I think you'll agree. And the 2 main causes every year really come out as failure to identify the patient correctly and labelling the blood samples away from the patient. And quite frequently, these errors do occur together. But remember that failure to identify the patient correctly. The maternity wrong blood in tube cases last year were reported as 35% of the wrong blood in tubes. But we do know that, of course, midwives take an awful lot of blood samples, don't you? You have 2 samples per antenatal patient, and then quite often there is the sample at delivery. I did mention earlier about there is a new category now for SHOT this year, and that is about cord blood samples being mislabeled or discrepant. Caroline, over to you.
Okay, so what is causing these sampling errors? Well, you just saw from my previous examples that workarounds are quite common and can often become acceptable practice in busy wards. We are over-familiar sometimes with our patients and don't always ask them to identify themselves. We multitask, we have distractions, and there's things like staff rotation, for example, rotational midwives in and out of community and different areas. We may be unfamiliar with our surroundings, and some of our work colleagues covering antenatal clinics at different surgeries could be an example. Stress and emotional demands, interruptions, the workload and staff to patient ratio, which very often in incidents that we deal with, we do see that as a contributing factor. The urgency of the situations that can be quite emotive in major obstetric hemorrhage, etc. And also a lack of training for tasks that should be completed by one person, often get completed by a team due to the time constraints and the desire that we have to help our colleagues and get the work done. Next slide, please, Terrie. Reasons why samples are rejected. You may be aware that there's a national comparative audit on sample labelling currently in the process of being reported. And preliminary results show that the core patient identifiers don't match on the tube and form as the main cause of sample rejection. And I did note on Erica's slide earlier on, when she was talking about rejection of samples for anti-D, there was quite a chunk where the form and the sample don't match. At Milton Keynes, we've been doing some auditing, which we will share with the East of England when we finish and write up the audit, looking at sampling. And we did discover that requesting group and save samples electronically actually leads to a 50% reduction in sample rejection. So that's for another time, but it was quite interesting and quite surprising. Next slide, please, Terrie. You talked, and Terrie talked in this slide previous about positive patient identification. And positive patient identification is taught as a way to prevent patient identification errors. But what is it? And this is the definition that we were able to find. And it states, the World Health Organization states, a primary responsibility of healthcare workers is to check the identity of patients and match the correct patients with the correct care, laboratory results, specimens, procedures before that care is administered. So I know we all know what it is, but are we actually practicing it? Next slide, please, Terrie. Wherever possible, patients for blood sampling or transfusion should be asked to state their name and date of birth, and this must exactly match the documentation and the details on the identification band. Notice I said documentation. You should always have that documentation and check it with the patient before you start to take the sample. However, I'm acutely aware that there will be within this meeting a lot of community midwives. Your patients are not going to be wearing wristbands. So you really need to rely more on the patient themselves. You need to engage with that patient, checking their address, unusual spellings of name, similar names, etc. So you've got a bigger job to do out in the community with your positive patient identification. Slide, please, Terrie. Do you know who I am? These are some quotes from the SHOT report 2021. The most common reason stated for wrong blood and tube events was a failure to identify the patient correctly at phlebotomy. And studies have shown that involving the patient in their own care can lead to improvement in professional practice. So perhaps something that you could do is you could ask the patient to check the details on that bottle of blood after you take it, prior to packing it up and sending it away, because the patient may be able to correct the spelling of their name, putting an E instead of an I, etc. Next slide, please, Terrie. I think it's your turn.
So patient identification isn't routinely performed correctly. We can see that now from the figures. And why is this? We should be asking them to state their name and date of birth rather than saying to them, are you X, are you Y? And it's because we do know that workarounds become accepted practice, perhaps because of shortage of staff, lack of space or equipment, or you want to complete the task quickly. And I want to ask you today, do you actually know what the correct process is for taking and labelling your patient's blood sample in your hospital? Have you got an SOP? Have you got any guidance at all? And does it take into account different situations? For example, samples in the community, as Caroline's just said, you haven't got wristbands, you've just got the patient, and therefore you do need to rely more on the patient or the woman, in midwife's case, of course, themselves. And of course, in an inpatient ward, then you have patients with wristbands. So you really need different processes. dependent on the situation. And I ask you, do you have these processes? Has anybody ever taught you about good patient identification, good patient sampling? And if they haven't, then this is something perhaps you should be asking for. So your processes is, say, when you leave here today, I want you to think about your processes, where you work. And if you do have any phlebotomy errors, if you've ever had one yourself, do you personally get a lot of rejected samples? And is this because your processes could be improved? You arrive at a surgery, perhaps, where you're going to see 10 antenatal women in the afternoon, and you've got to arrive with perhaps their labels already printed, their request forms, etc. You want to think about, can you do this better? If you're getting a lot of rejected samples, can you make your process better? And if you can, then please, you must speak out, make suggestions, get things changed. We just wanted to bring this to your attention. So the HSIB is the Healthcare Safety Investigation Branch, HSIB, and they will investigate anything that they're asked to investigate if they think it's a serious enough thing for them. And they were asked to investigate a wrong patient details on a blood sample in a midwifery unit. Public Health England figures that were made available to the investigation showed that wrong blood in tube incidents accounted for 3% of all the incidents reported under its antenatal blood screening programmes in 2018 and 2019. This investigation found that the processes followed by the staff varied depending on their personal experience and the environmental conditions and the status of the patient, and that significant variation existed in the blood sampling practice in the unit. Staff told the investigation that if the computer couldn't be accessed, they would begin the blood sampling process without actually having a request form. And the area where the incident occurred had a single computer that was used by so many people. This report is actually available online. Just Google it, HSIB, wrong blood, wrong patient details or whatever. It makes very interesting reading, and particularly for you midwives.
Okay, so I'm conscious that we are running over time, so I'll very quickly go through the observations from our experience. We found that often when there's an incident, we don't focus on the consequences and potential harm of the wrong blood sample, about the wrong HB, the wrong RH group, antibodies missed, etc. We also noticed that incident feedback is not always received by the relevant staff, and almost a relief that, oh, well, it's a no harm incident, so therefore we'll not worry too much about that. Sample collection primarily focuses on venipuncture technique, and we would like to see, and we hope going forward, that there'll be more of an emphasis within those packages of positive patient identification. I did say earlier on that if the request card, electronic or paper, is not there at the beginning, you will make an error. You have more potential to make an error. And the other problem is that senior management are more focused on the never events, not any near misses. But a wrong blood in tube can actually lead to an ever event. And I know that the group check mitigates for the wrong blood in tube, but are we now pushing that further down the line and saying, well, if we make an error, the lab are going to discover it and everything will be okay? So it's about thinking about the fact that you work under pressure, you have stress, but you don't want to have shortcuts. And that's what we find. Staff make shortcuts and workarounds. Again, just to remind you, the BSH guidance is clear. One patient, one component, one competent member of staff to perform one continuous uninterrupted event. Next slide, please, Terry. So that's the BSH recommendation. Terry and I investigate lots of incidents, and our recommendations in addition to that would be that for venipuncture and cannulation courses, they should include more emphasis on patient ID at all steps. Then number 2, go back and look at your processes, see if there's an SOP. Is it fit for purpose? Do you actually need one? View the shot sampling video, or your trust may have a video about sampling to help you with your practice. Feedback findings about sampling errors to the right people, Put it as message of the week. Think how you can make everybody and share this learning. Are you involving the patient in the process? Why not ask the patient to check the sample? It's good practice. And finally, ask your TP, do they audit sample errors? They may well do audits in your area. And if they are, it can help you identify where your errors are occurring, and you may want to change your practice. Otherwise, you may know that you're not making any errors, and that's great. You can audit to look for that as well. But those are our recommendations in addition to what the BSH guidance says. Over to you, Terrie.
So we know that as midwives you practice the 6 C's: care, compassion, etc. And we'd like you to go away practicing the 4 P's: perfect, process, and positive patient identification.
Thank you, everybody. Any
thank
questions?
you. Any questions? Yeah.